So I'm John Page again from LSU New Orleans, and it's my pleasure to introduce Marin Anvari. He has been a leader in telerobotics since 1996, and he has worked with the military closely. You saw through some of those DARPA studies that we just saw, and has done a lot of work with automation in telerobotics. He is the scientific director of telerobotics and a professor of surgery at McMaster, and he is the past president of MIRA, which is the Robotics Association. So he's going to talk to us about practical use of automation in robotic surgery.
Thank you very much, John, and thanks, Tim, for laying the foundation for what I need to really help you see how some of the vision and the research that Tim mentioned, a lot of it which came from actually the military application of the needs has led to some changes in the medical world, and I hope to take you through that. My disclosures, as was mentioned, I'm a scientific officer of an institute which is developing new robotic systems and holds some patents. I'm on the advisory committee for Ethicon, and I'm a little bit privy to the current merger with Google. I can't go too much, but I can attest to what Tim said. I think it's quite an exciting era which is ahead of us. And I've had relationship with a number of other companies, all of which are actually entering robotics. Stryker certainly is a long way through that. And again, I can say some things in my talk, but to limit, but there are some exciting things around the corner for them as well. As was mentioned, the term robot is often misused because it was initially coined by the Czech writer Karel Čapek, 1921, and it really implies automated, repeated actions in an automated way, whereas as the current system that we use, we term robot, doesn't do any automation action. And I think these are the terms that I think already Tim has discussed it. This video is something that you've all seen, is the start of the investment in surgical robotics, and it's the US military's vision of where medevac evacuations are going to be in 10 years from now. This is from 1990s.
Medevac. Medevac.
When this was produced, many of these were just ideas. Most of these are now reality. Almost every piece that you see in this video in less than 15 years has been made and is now in use. So sometimes these type of visions lead to reality. And this was the medical robotics, which was the cause of investment in SRI M7, which later became the Vinci robot, for primarily military use. It was first demonstrated in 1996 to the generals, and the comment was that it was way too big, and that led to commercialization of the IP rather than its military application. But certainly the number of components which were produced out of investment in this program, and Tim mentioned the TraumaPod program, has become reality. The Predator and the drone systems are one derivative of the investment made in that program towards an automated medevac. As was mentioned, one of the benefactors of that investment was us, surgeons. This is the original M7. Some of you remember John Bowersox, who was very much involved in the early development with SRI group. He was the clinician surgeon involved, and that led to a development of the M7 robot, which, as Tim mentioned, we use in a number of NEMO projects to evaluate the use of remote telesurgery in extreme environment. As Tim said, I had done telesurgery, but from one clinical site to another, it's very different when you actually have to take a robot in a very remote environment and operate in a very difficult situation. We looked at time delays of up to 2 seconds and realized that once you go above 300 milliseconds, you really cannot do fine surgical actions, and you really need some degree of automation and autonomy. And I think that led to some of the work. And in NEMO 12, as Tim showed, we demonstrated some degree of automated action. and I'm going to take you through some of the work that's been done. Obviously, the biggest name in the field of robotics that everybody associates is the Vinci System, which is in fact a master-slave device. It's not a true robot. It did have robotic capabilities. It had haptics. It had some automation capabilities, but in the course of its development and going through FDA, all of those capabilities were removed. But the current system is a great surgeon assistant in doing procedures, and you can't certainly argue with their success. And as you can see, there has been a steady growth in their financial situation, and anybody who had invested in the company did well. And certainly there's been an increase in number of Da Vinci surgeries in all fields, particularly urology and gynecology, although general surgery is the next frontier that they have targeted. When you look at the investors' idea where robotics is going to go, I think they're all banking on automation and autonomous robots being the next generation of robotics. And in fact, you can see the market estimation of where the investments are going to be is in the field of automation in robotics and autonomous, and I'm glad to see that. One of the earliest robots capable of some degree of automated action was Robodog. Obviously, it wasn't in its current format. The first Robodog surgery was done in 1990. This is for a hip arthroplasty, and it did a very small portion of the procedure in a programmed manner. It has certainly come a long way, and it's the fact that it's still available is amazing. First surgical robot that we all as general surgeon use was ESOP. This is, and it's certainly capable of automated action in holding cameras, positioning, and I don't know, some of the younger surgeons probably haven't seen one. This is me in 1996 doing a right hemicolectomy with ESOP. And certainly it was a great way of performing, so holding the camera for the surgeon. Believe it or not, that first ESOP is still in use in our institution. We've got 2 others, and it's still being used by some who love it. So it shows that these type of very simple robots have a longevity, whereas the more complex you get, the less. The first true automated a robotic system which actually received FDA clearance, it was CyberKnife. Some of you have seen this operate. It's actually dual robots, both the actual robot which controls the gamma ray, but also the bed itself is robotic. And these 2 robots, if anybody has seen it, and I'm sorry that the video is not running. Let me see if I can run it. It actually allows the 2 systems are programmed to radiate the patient at various multiple angles, hundreds of different angles, to minimize the radiation dose, and the radiation focus is right on the tumor. This really was a big test for FDA, and clearing this degree of automation in providing medical surgical care. And really that has acted as a predicate for all the new automated systems which are coming to the market. Until then, it was tough. Even though ESOP had received FDA clearance, it was not performing a surgical act. It was just assisting, whereas this is actually really radiating the patient in an automated fashion. Now, Mako is a robotic system for knee arthroplasty. And in the surface, it really is quite a simple system which helps the surgeon resurface the knee. This company was purchased by Stryker a year ago for $1.6 billion. I can tell you in 2 years from now, you will have a fully automated knee replacement in the market. So they have taken this, they needed some of the background patents that Mako had. They didn't buy it because of the capability of this system, but for the patents. And I think the field of orthopedics is undergoing major change in the next 2 years, with high degree of automation, robotics coming into their procedures. And I think for our field, it's somewhere in the future. My own interest has been, as I said, understanding automation, and we developed a system, image-guided automated robot, which can have many applications. The first application of the whole idea behind it is to use imaging, real-time imaging, to allow the robot to perform a pre-plan, is in the area of early breast diagnosis and treatment, ablation with cryotherapy. The system is now undergoing phase 1 clinical trials. And again, for because of my disclosure, I'm not going to go, this is not commercialized yet, but just to say that there's a big difference between a robotic system and a manual performance of not only the breast biopsy, but breast ablation of a fine tumor. And again, this is where I think robotics and automation is going to go. They're going to go smaller, more disease-specific or procedure-specific, and allow things to be done where radiologists, surgeons really cannot. To do real-time MRI, this is inside the bore of the MRI, imaging and performing tasks is almost impossible for radiologists. They have to shuttle the patient out. Now the robots are able. So this is where really automation will allow you to do, is to extend the capability of what we can do in our manual hand. There are a number of platforms for general surgery, for orthopedics, for urology, which are on the horizon, and certainly we believe that the whole idea of image-guided robotic systems are going to be the future. Now, ours is not the only one in the development. There are a whole series of robots which are either under development or on the market, all with some degree of automation now built in, unlike Da Vinci, which is capable of performing a variety of tasks which are repeatable. So the pros of automation it certainly allows pre-planning, which allows the radiologist, surgeon, whoever is doing it, to plan the procedure, practice it in a virtual modality, see if it's really what they want to do, and then press the start button. It does offer more accuracy, better targeting, lack of fatigue in repeating the same tasks. And I think for the patient, if we are all for the minimally invasive, certainly all of these allow us to perform procedures in the least invasive procedure, and it certainly improves patient experience in all of these. But more importantly, from my point of view, what automation brings is to perform tasks which are not humanly possible. As I said, the current system, the Da Vinci, it just enhances your ability to suture, to dissect. It does not take you to the next, frankly, paradigm shift, which is to do procedures that you cannot do manually yourself. And I think that's where the automation will bring you, not only for real-time targeting, which our brain doesn't have the computing power to use multiple sensory inputs from imaging, from haptics, from various things, and to do this, as well as non-invasive approaches and performing multiple tasks simultaneously. And I think we are very sophisticated machines ourselves, but I think the power of the computer is taking us to the next generation where we actually can plan very complex actions that the robots can perform on our behalf. The cons of automation and robotics is that there are, at the moment, as Tim said, they don't have autonomy. They don't have ability to have a decision tree built into that action so they can think on themselves, but that's next. The ability to change from one case to another and sort of be able to do a variety of procedures is more difficult for most automated robots because they're designed to do specific series of tasks quite well. And I think these are the things which need to be built. And most importantly, they need to be costly, cost-effective, and that's been a challenge for all robotic systems to come at a cost level that is something everyone can use. As Tim mentioned, autonomous robots are around the corner. There is still a great deal of research being done in various centers which look at autonomy. This is a project in Berkeley using Da Vinci in an autonomous fashion to perform very simple tasks of dissection, cutting, and allow the system to alter its movement based on the change in circumstances. So some degree of decision making is built into the programming. Again, in Nemo we did test that. We realized that it's not difficult to build that. It's just more complex. And the more complex the surgical task, the more complex that decision tree needs to become. But autonomy is definitely approachable. And as Tim said, the Google J&J partnership to develop neurosurgical robots, I can tell you, is to develop autonomous robots. And I think that's a very exciting new development, and I think we're going to hear a lot in the next few years from that partnership. As Tim mentioned, the science of autonomy is far advanced in other fields except medicine. and now they're going to bring that knowledge that they've created into the medical field, into the surgical field, and I think the next generation of autonomous robots are going to be very exciting. So in conclusion, as sort of as our final learning points, automation will enhance robotic surgical actions. There are, I think, more and more you're going to see significant increase in the number of task-driven robotic systems, so specific application, and we're going to see increasing image-guided systems, and autonomous work systems are in the progress, but I think they're not that far behind. Thank you very much.